nanoparticles and can send it directly to the tumor. So tumors will get these nanoparticles in very high concentration. Then those days we use chemotherapy depending on your histology and anatomy. But now you don't do that. One example is, say, if you see a stage 2 bowel cancer, where you think the patient is having high risk factors like poor differentiation and things like that, then one may think, even if the notes are negative, one may think to go for chemotherapy. So if you are thinking for chemotherapy, if the patient is having high MSI, microsatellite instability or mismatch repair gene, then it's no point using 5FU. 5FU is not going to be effective in that scenario. So we need to find out exactly what is happening. And again, we use biological markers before you use chemotherapy. Now, the classic example is, if you want to use 5FU for a patient, it is always better to do DPD deficiency, because you can do that genotypically or phenotypically. Facilities are available. So the NCC guidelines very clearly say to do DPD deficiency before you use 5FU. If the patient is deficient of DPD, better not, or either reduce the dose. Then there are interventional radiological techniques like transarterial chemoembolization, radiofrequency ablation, microwave ablation, and selective internal radiotherapy. So these are done with the help of the interventional radiologist, where you can treat the tumor directly without damaging other areas. So this is basically done for hepatic tumors, hepatic primaries, as well as hepatic secondaries. Then hormone therapy is another modality. I'm very simple and straightforward, because some hormones can stimulate cancer cells like breast, prostate, endometrial. And when you manipulate the hormonal environment, by manipulating, you can sort of reduce the activity of those malignant cells. Then the immunotherapy, another modality. There are naturally occurring cytokines like interferons and interleukins, which can be produced synthetically now, and that will enhance the cell-mediated immunity. Cell-mediated immunity is very important in counteracting malignancies, in fighting malignancies. So special T cell functions, so both will improve the T cell function. Then you have another one called the immune checkpoint inhibitors. This is a very novel concept. There are PD-L1, PD-1, and CTLA-4 drugs like atezolizumab, nivolumab, ipilimumab. They are expensive though. The concept is, now you see now see, this is a malignant, say, forget about the tumor cell, consider that as a normal cell. They have the PD-L1 ligand, and all the cytotoxic T cells have the receptor for that ligand PD-1. So during normal circulation, when these cytotoxic T cells meet the normal cells, if they have the PD-L1, they understand, they recognize each other, and they say hi to each other, and they go either way. They don't attack the cell. So these malignant cells also, inadvertently, they produce PD-L1 to cheat your T cells. So by doing that, malignant cells will evade action, the cytotoxic action of T cell. So when you block these checkpoints by various drugs, then of course, the cheating can be prevented. Cheating can be cheated rather. So by doing that, you can have a better effect of T cell. But only thing, they have a lot of side effects. They can induce an element of autoimmunity. So you have to be extremely careful. They are expensive. Then you have the other immunomodulatory drugs like thalidomide, lenalidomide, and pomalidomide. You know that you are using that mostly in myelomas. And they also enhance cytokine production and T cell stimulation. Then monoclonal antibodies. Now, tumors have specific antigens against which monoclonal antibodies can be raised. So they can be either pure antibodies like trastuzumab we are using for anti-HER2, and they can be chemotherapy tagged, like the Trojan horse concept. They can be tagged with chemotherapy. The classic example is they can be tagged with DMI drug. So this is called the trastuzumab emtansine, TDMI1, used for breast cancer. And thirdly, they can be even tagged with radioisotopes. So now anti-CD antibody can be tagged with yttrium-90. So this is ipilimumab tuxetan, which can be used very, very effectively to treat certain lymphomas, CD20 positive lymphomas. Then tyrosine kinase inhibitors, they are cellular signal inhibitors. You all know about this, everyone is using this. If you look at this, now tyrosine kinase is a molecule which is situated across the cell membrane. There are three portions: outside, extracellular ligand binding site, the transmembrane portion, and the intracellular catalytic site. So under normal circumstances, when growth factors bind to this ligand binding site, there will be activation and phosphorylation, and that will help normal cell division. But malignant cells also produce a lot of tyrosine kinase molecules. But unfortunately, either they are mutated or they are overexpressed. So when they bind the ligand, or bind the growth factors, they send abnormal signals, and that will help in malignant growth. So there are drugs to, I mean, if you find out there are tyrosine kinase mutation or amplification, there are drugs to block these ligand binding sites. You call them tyrosine kinase inhibitors, and these are the classic examples: gefitinib, elotinib, and osimertinib. These are few. There are hundreds, but these are few commonly used examples. Then there are PARP inhibitors. During cell division, there can be a lot of DNA damages. So when there's a single strand damage, when the DNA is duplicated, the damage will also be duplicated, and the cell will not be able to survive. Okay, so there's a under normal circumstances, there's a enzyme called PARP. The PARP will repair this, but when you inhibit the PARP, this repair cannot happen. So when the cells are duplicated, even the damages will be duplicated, and ultimately cell will not be compatible with long life. So that is what we do by PARP inhibitor. So this is very important in certain tumors where the BRCA is mutated, where there are so many cell damages, and by doing that you can get rid of the tumor. So they are basically using BRCA positive ovarian and breast cancer. And finally, we are using now personalized medicine. We don't, before you do start chemotherapy, even for diagnosis, you use personalized medicine. You are going to the genomic level. You analyze genes. So it is important as a diagnostic tool. It is important as a prognostic tool, as a predictive tool to predict the treatment outcome. So that will tell you exactly whether that patient is going to benefit from chemotherapy or not. So nowadays, most of the centers of excellence, they go for the genomic analysis before you start the correct treatment. So these are few genomic things available, like Oncotype DX, where you analyze about 21 genes. The MammaPrint, you analyze about 70 odd genes, GeneFX colon, GeneFX lung. So when you do this, you know exactly where you stand. The diagnosis, the prognosis, and the type of drugs that are going to be effective. And finally, now we go for this new term, theranostics. So there's a combination of therapeutics and diagnostics. So nowadays, when from diagnosis until the treatment, you use this theranostic concept, because that will combine your diagnostic as well as therapeutic parameters together with the genomic analysis. So this is the personalized approach to cancer treatment. I think I did not take a lot of time. Thank you very much for your attention.
Thank you very much, sir, for that covered 360 purview of the oncological management in general. Let me now invite the next presenter. It will be on oncological emergencies. I hope the medical officers and the junior doctors will find this lecture very practically useful. I would invite now my dearest colleague and the friend, Dr. Devinda Jayatilaka, consultant hemato-oncologist at the National Cancer Institute, Maharagama, to deliver this speech for you. Dr. Devinda is the first ever board-certified consultant in hemato-oncology in Sri Lanka, and he successfully completed his fellowship in hemato-oncology and bone marrow transplantation in the Queen Elizabeth Hospital, Birmingham, United Kingdom. So pre-recorded lecture will be played by now. So it's time for the next lecture.
Good morning. I'm very grateful to the Council of the Sri Lanka College of Oncologists for giving me this opportunity and presenting at the annual academic sessions 2021. So I've been asked to talk about two topics of oncological emergencies, Tumour lysis syndrome and febrile neutropenia. So they are very common basic topics, yet vitally important in clinical practice of oncology. So Tumour lysis syndrome, or TLS, is a metabolic complication that can occur during chemotherapy or radiotherapy for certain malignancies. The TLS is caused by excessive release of intracellular metabolites from cells, which overwhelms the normal homeostatic control mechanisms and leads directly to increases in plasma uric acid, phosphates, potassium, and reduction in plasma calcium. This TLS is particularly likely to occur during induction chemotherapy when there is a high tumor burden, as well as when the tumor cells have increased sensitivity to antimitotic agents. So according to this Cairo-Bishop definition, when a patient has one or more of these biochemical rearrangements related to tumor lysis, patient has laboratory tumor lysis. With the evidence of laboratory tumor lysis syndrome, if the patient has one or more of those clinical features, then the patient has clinical tumor lysis syndrome. So this is a summary of pathophysiology of tumor lysis. So basically, the metabolic effects of TLS are caused by the release of intracellular potassium, phosphates, and nucleic acid. The nucleic acid metabolism produces large amounts of uric acid. In patients with high tumor burden, the normal homeostatic mechanisms for dealing with the release of cellular contents from dying cells are often overwhelmed, causing laboratory and then clinical TLS. First, to observe in tumor lysis is the hyperkalemia. This occurs as quickly as 6 hours after the start of chemotherapy and may be severe enough to cause immediate life-threatening complications. Simultaneously, as a direct consequence of hyperuricemia, uric acid crystals precipitate in the renal tubules, particularly in the acidic environment of the distal renal tubules. And that causes a reduction in the ability of the kidneys to excrete the products of cellular destruction. So the renal functions becomes further compromised as a result of the hyperphosphatemia, because this increased phosphates binds with calcium and cause calcium phosphate crystal. These crystals also get deposited in the renal parenchyma and again further contributes to kidney injury. So the development of acute kidney injury causes further accumulation of potassium, and the consequent acidosis further accelerates the crystallization of uric acid and calcium phosphate. It acts as a vicious cycle. And at this point, the situation spirals out of control, causing a cascade of clinical TLS. Now, there are a number of well-recognized risk factors for development of TLS. High tumor burden, high-grade tumors with rapid cell turnover, pre-existing renal impairment, as well as increased age are some of them. But in essence, all those are related to the high tumor volume and also the rapidity of cellular breakdown. So various malignancies are categorized into low risk, intermediate risk, and high risk for tumor lysis, depending on the aggressiveness of the disease. Most of the solid malignancies belong to low risk category, but on the other hand, most of the acute leukemia, particularly acute lymphoblastic leukemia and acute myeloid leukemia with a very high WBC count, belongs to high risk category. Then the management. The key to the management of TLS is recognizing those patients at risk of developing syndrome and use appropriate prophylactic measure. Sometimes it will be little difficult to completely eradicate the TLS because a small proportion of patients with aggressive tumors develops spontaneous TLS even prior to start of therapy. Then the key drug in the management of TLS is allopurinol. So this allopurinol is a xanthine oxidase inhibitor. Let me go back to this chart. You can see that allopurinol is a xanthine oxidase inhibitor. and it decreases the formation of uric acid by inhibiting the conversion of hypoxanthine xanthine and xanthine into uric acid. Because both this hypoxanthine and xanthine are relatively more soluble than uric acid, this reduces the formation of uric acid crystals in the renal tube. And thereby, it helps to reduce the formation of uric acid salt. However, a point to remember is that this allopurinol does not increase the rate of breakdown of uric acid that has been already formed. So its therapeutic effect is 24 to 40, 72 hours delay. But on the other hand, the drug called respiratories is a very effective agent to treat and manage the lysis. This respiratories is a recombinant form of the enzyme urate oxidase. This urate oxidase is an endogenous enzyme commonly found in most of the mammalian species, but unfortunately it is not present in humans as a consequence of the acquisition of a nonsense mutation in the coding region of that particular gene during hominoid evolution. So this respiratories metabolizes the urate and it converts the uric acid into allantoin. This allantoin is approximately 5 to 10 times more water soluble than uric acid. So it is an extremely effective agent, and it will reduce the plasma levels of uric acid within 4 hours after its intravenous administration. Let's go back to our management slide. So the standard recommended dosing schedule for allopurinol for tumor lysis is 200 to 400 milligram per square meter per day. But commonly we use 300 milligram fixed dose for adults. But in desperate situations, the dose can be increased up to a maximum of 800 milligrams per day. At the same time, you should keep in mind that the allopurinol doses needs to be adjusted in renal failure. Respiratory is also indicated as a prophylactic agent in high-risk patients. The licensed dose is 0.2 milligram per kilogram body weight. But for adults, often we use 3 milligram fixed dose, which is very effective. The next step in prevention and management of ALS is to maintain high urine output with adequate hydration. The aim of adequate hydration is to prevent uric acid crystallization and calcium phosphate deposition in renal tube. But once the tumor lysis syndrome is established, the drug of choice is respiratories. These patients must be carefully monitored. The fluid balance must be regularly checked. The electrolytes must be rigorously monitored and corrected accordingly. However, hypocalcemia, asymptomatic hypocalcemia, should not be treated. Because if you give more and more calcium, it contributes to the pathophysiological process of tumor lysis. But if the patient is symptomatic with hypocalcemia, then use intravenous calcium gluconate. But the aim of treatment is just to relieve the symptoms, but not to correct the hypocalcemia. Despite these measures, if the tumor lysis process progresses, then a patient might need hemodialysis, renal dialysis. A couple of points to remember with regard to this respiratory cases is contraindicated in G6PD deficiency. So, in pediatric setup, especially, we have to be careful and exclude G6PD deficiency before using respiratory test. Otherwise, it cause hemolytic anemia. The other is that once you use respiratories, and if you are checking serum uric acid levels, the samples must be sent in ice. Otherwise, you can get a falsely low assay. Yeah, that's all about the tumor lysis. Then we'll move to febrile neutropenia. So what is febrile neutropenia? So febrile neutropenia is fever as a single oral temperature more than 38.3 degrees or temperature greater than 38 degrees for more than 2 hours. Plus neutrophil count less than 500 or expected to fall below 500 over next period. It is one of the commonest causes of mortality and morbidity in cancer patients, and it accounts for about 20 to 30% of morbidity and about 10% of mortality in cancer patients. It's a medical emergency. Therefore, the proper management of patients with febrile neutropenia is life-saving. So once we suspected the patient with febrile neutropenia, we do the proper assessment, history and physical examination to begin with. During the history, the important things to note are type of malignancy that the patient is having, the chemotherapy regime that has been used, and the timing of chemotherapy. Patient must be quickly evaluated and check the vital signs. If the patient is hemodynamically unstable, the patient must be resuscitated and optimized. Otherwise, you can take some time and do a proper physical examination. The idea of proper physical examination is to look for a possible focus of infection. Then the blood investigations must be sent urgently: blood count, renal function test, liver function test, electrolytes, and then blood cultures and urine cultures must be sent. Suspecting a lower respiratory tract infection, sputum culture and chest X-ray are also indicated. Patients with febrile neutropenia are broadly divided into two groups: high-risk groups, high-risk patients, and low-risk patients. Patients with prolonged neutropenia for more than 7 days and profound neutropenia with absolute neutrophil count less than 100, and those with comorbidities, as well as certain signs and symptoms like hypotension, intra-abdominal sepsis, or neurological signs, belongs to high-risk category. Those patients do not have those clinical features, belongs to low-risk category. We have this MSCC scoring system to objectively categorize those patients. Depending on clinical signs and symptoms, the patients are given a score. And when the total score is less than 21, patients belongs to high-risk category. Low-risk patients can be managed as an outpatient with oral antibiotics. However, patients must be carefully advised to get themselves admitted if the fever is not settling or if they develop any new clinical symptoms. High-risk patients, on the other hand, need immediate hospital admission. And the single most important key step in the management of high-risk patients with febrile neutropenia is urgent initiation of broad-spectrum intravenous antibiotics. When you can't identify a focus, the empirical regime is initiated. Generally, this empirical regime consists of a beta-lactam antibiotic with an aminoglycoside. The combination depends on the institutional policy. Vancomycin or teicoplanin generally not recommended as a standard part of the initial antibiotic regime. However, if a patient is having skin or soft tissue infection, pneumonia, catheter-related infection, or if the patient is hemodynamically unstable, then the vancomycin or teicoplanin must be added into your empirical regime. And also, if you have focus of infection, your regime must be tailored to cover the focus. Then appropriate use of GCSF is also important, but the urgent initiation of appropriate intravenous antibiotics is the key to success, and it's a life-saving measure. After initiation of these broad spectrum antibiotics and adequate supportive care, patient must be regularly monitored within first 24 to 48 hours. If the patient is clinically deteriorated, despite the broad spectrum of antibiotics, you might have to escalate the antibiotics. But if the patient is clinically stable, but the fever is not settling after 72 hours of broad spectrum antibiotics, then empirical antifungals are indicated. The duration of antibiotics. So if you have a documented site of infection, the antibiotics must be continued until the resolution of signs and symptoms. And once the patient clinically is stable and effective for more than 3 days, intravenous antibiotics can be changed to oral form. But if the patient has septicemia, soft tissue infection, pneumonia, generally the antibiotic must be continued up to 10 to 14 days. I think that's all about my presentation. I would like to thank for your kind attention, and I'm very happy to take any questions during Q&A session. Thank you.
Thank you very much, Dr. Devendra Jayatilaka, for that very simple but very concise presentation. And let me now invite for Dr. M.S. Hamid, consultant orthopedic surgeon at the Provincial General Hospital, Badulla, for the next lecture. It's on spinal metastasis. Let's hear the surgeon's point of view on spinal metastasis.
Good morning. Thank you, Dr. Buddhika. At the outset, I would like to thank the College of Oncologists for inviting an orthopedic surgeon to your prestigious forum to deliver a talk. So my talk today would be about spinal metastasis, a surgeon's point of view. So before going on to the actual topic itself, I would like to discuss about a classic case. So this was a 50-year-old lady who had a history of breast cancer. She had a mastectomy and axillary clearance 3 years back, and she had radiotherapy as well. So when she met me, she was still on tamoxifen. So her history goes as such. She had significant back pain for the last 2 months, which has got progressively worse. And she had bilateral shooting leg pain along her legs when she's standing up, along with numbness. And she had significantly reduced mobility. So she was literally wheelchair bound. She arrived us. But her sphincters were intact. On clinical examination, she had weakness in her L5 distribution in her left leg with sensory loss. Right. So this is a MRI scan. So I've got a fat suppression, sagittal weave on the left side, and a corresponding axial weave on the right side across the L5 vertebra. So you can see the L5 region, there is very high intensity, which suggests there's a tumor process going on. And it's also fractured at that level. And you can see there is enormous amount of lesion at the back of the spine as well. So on the axial cut, on the right-hand side, so this is a fractured bone which has protruded into the canal, and the chorda equina at that level is virtually obliterated. So she is unstable in terms of her spinal stability. She's got neurology. So we did a CT scan just to stage the patient. We identified there were a couple of pelvic lesions. Otherwise, there was no other solid organ beds. After having a conversation with the oncologist, we decided to operate. So what we did was, this is the post-op images. We went from the back. We chose the spines from around L3 level to S2 level. So we put titanium metal screws into these vertebrae and connected with the rod. And we decompressed the spine by taking off the back portion of the entire spine, which we call laminectomy. And we decompress the whole spinal cord from the tumor. Subsequently, she received radiotherapy and chemotherapy. So 1 year down the line post-operatively, she's still independently mobile, and her sphincters are continent, and then her pain was quite low level. So the prevalence of spinal metastasis may differ based on what you read. So most of it quote somewhere around 20%. So out of which about 5 to 10% of them will present with spinal cord compression. It is more prevalent in the thoracic spinal segment purely because the bone mass of the thoracic spine is higher and the blood supply to it is proportionately high as well. About 20 to 35% of them can present with multiple sites of metastatic spinal cord compression. So how do they present? So there are classically 3 ways that they could present. So either they could be under your follow-up, the oncologist, they may present with neurological symptoms or signs of significant back pain. Or a patient with cancer history, they may present to other specialties like even a GP or primary care facility with significant back pain or neurological symptoms. Thirdly, less frequently, patient as his first manifestation can present with metastatic spinal cord symptoms of neurology or back pain to anybody else other than an oncologist. So I just wanted to show this form. So this is a sort of a form distributed among all the primary care providers in the UK to assess patients who come with back pains. So these are called red flags. So if any of these boxes are ticked, so they warrant immediate, early or urgent referral to a spinal care facility nearby. So some of things which are important to our topic is the age of a patient. So anybody over 55 who's having intractable back pain or neck pain for a little longer, it needs evaluation. So I'll come to the thoracic pain. The rest of it is quite straightforward. So anybody with neurology can be meds or can be anything else. So night pain and non-mechanical pain is quite significant because they would imply that it's something like a cancerous process or an infective process is going on. Anybody with a structural deformity due to a pathological fracture, that's a low intensity spinal fracture coming with deformity, it's significant, and a history of cancer. So why is thoracic pain important is because one thing is I told you, metastatic spinal cancer predominantly involves the thoracic spine, one. Secondly, we all end up getting neck pain and back pain. That is because unlike the thoracic spine, the cervical spine and the lumbar spine is the mobile part of our spine. So they are more susceptible to degenerative changes and back and neck pain hence. So if you have a thoracic pain, which is part of your rigid spine, so it's a bit more significant, so you need to take into consideration. So their pain can be either biological pain, it's due to cancer-related destruction of the bone, or instability pain, which we will speak about later. They may have a wide array of neurological symptoms and signs. They may or may not present with a cancer history based on which part of the disease they are in, or they can purely present with just a pathological fracture. So from an investigation point of view, we always request for an MRI whole spine. So the MRI, so that incorporates, we at least request for a T1, T2, and fat suppression sagittal images, plus or minus contrast based on whether the previous cancer history is there, and axial images across the cut. So that will help us to identify the degree of spinal cord compression. And it also helps us to identify the contiguous vertebrae states. That's important because when we are instrumenting, when you're putting metal screws, if you have cancer in the adjacent vertebra, the pull-out strength is not adequate. So which means the implants may fail. So we might have to extend our fixation either more proximally or distally. And why an MRI whole spine is required is you may have concomitant lesions in them. It in itself is not a contraindication to operate, but it may change the whole picture of the patient and his prognosis. So you need some form of staging tool, at least a CT, to help to prognosticate the patient. And secondly, if the patient has no prior history of cancer, it will help us to identify a possible primary. And in the case of unknown primary, you might have to do a whole other rest of the workups like assessing for tumor markers, myeloma screen, bone marrow biopsies, so on and so forth. So broadly, there are 3 indications for surgery. Firstly, if there is neurological deficit, either imminent or impending. Then secondly, for spinal instability. Thirdly, there are patients due to pathological fractures, which does not cause any spinal instability, present with persistent back pain. So we have treatment options for them as well. So what are the goals of the surgery in metastatic spinal cord compression? Firstly, to restore their mechanical stability so that they can have an upright posture and be mobile. Secondly, to do a circumferential decompression of the spinal cord, either restore their neurology or to regain the lost neurology. Thirdly, to help deliver a good tumoricidal radiation dose to the entire tumor without causing any toxicity to the spinal cord. So the overall, the essence is we are helping them to be on their feet and to be mobile and to improve their quality of life. So it's true that the treatment of spinal metastasis is palliative, but it's important that we are trying to give them a good quality of life for their surviving period. So firstly, the neurological deficit. They can either present with complete abrupt neurological deficit based on how bad the tumor progression is in their cancer, or they can present slowly with some other symptoms. They can come with radicular symptoms due to nerve root compression. Spinal cord compression may cause myelopathic symptoms, or the cord equina compression can cause lower limb weakness, numbness, or saddle anesthesia, or sphincter disturbances. So they can have a wide array of presentation. It also has to be matched with radiology. So this is what we do while we do an MRI scan. So based on how the tumor is compressing the spinal cord, we got this grading system, which broadly can be categorized as high grade and low grade based on how much the spinal cord is compressed. And then you also have to assess the oncology of the tumor. So when we mean the oncology, it's the responsiveness of the individual tumor to conventional external beam radiotherapy. On one end, you have radiosensitive hematological cancers like myeloma and lymphoma, or you have the radiosensitive solid organ tumors like breast and prostate. And at the other extremity, you have the whole array of radio-resistant cancers. Obviously, my oncological colleagues will agree that the availability of advanced techniques of radiotherapy like stereotactic radiosurgery or any other more image guiding techniques allows you to administer a large dose of radiation precisely to the tumor without causing any toxicity to the spinal cord. So availability of such techniques would change your threshold for surgery. So you will be left with these quite a few scenarios. So you may have a hematological malignancy with no neurology. So the answer is obvious, they benefit from radiotherapy. The second instance is you may have a hematological malignancy with neurology. At the moment, we have very good evidence that even this category will benefit with radiotherapy. So you have the radiosensitive solid organ cancers like breast and prostate with no neurology. So they may benefit from radiotherapy, but if they have high grade of spinal cord compression, we have a tendency to operate them. But obviously, if they are causing any neurology, they will more benefit from surgery plus radiotherapy rather than radiotherapy alone. So the radio-resistant cancer is the biggest dilemma because the availability of high advanced techniques of radiotherapy may differ a little bit in how you manage. But if you have low-grade epidural spinal cord compression, they are better off managed with radiotherapy. But if they have high-grade spinal cord compression with or without neurology, they will benefit from surgery followed by radiotherapy. So all these principles are stemmed by this important paper published by Roy Patchell in 2005. So he and team conducted this prospective randomized trial to compare radiotherapy versus surgery plus radiotherapy in the patient of metastatic spinal cord compression. So they noticed and they concluded that significantly more patients who were in the surgical group were ambulant post-treatment. They remained ambulatory for a longer period. The sphincters were continent and they had a longer survival period and their pain relief requirement was quite less. So the second indication is instability. So what is instability? So the cancer may go and invade your spine and cause destructive forces. So that may cause cancer destruction. And just like in the case of trauma, they may have spinal instability. How you assess them is they tend to have pain related to movement or recumbency when it's coming to thoracic or lumbar spine. Or they may have progressive deformity. So for example, if you get an X-ray on a standing or erect posture, the X-ray will show the pathological fracture is more compressed or causing deformity like a kyphosis compared to their supine X-rays. Thirdly, on their erect posture, they tend to have neurological symptoms. They tend to present with numbness or shooting pain along their limbs when they're standing up. So this constitutes what we call spinal instability. So instability is an independent indication for surgery, regardless of the degree of cord compression or the radiosensitivity of the tumor. So the biologic pain, which is more prevalent at night and during evenings, and it quite well responds to radiation, the instability pain is quite different. It depends on where the tumor is. For example, if you have cervical spine instability, you tend to have significant pain with flexion extension of your neck. If it's above C2, you may have, with rotation forces, you have significant pain. If in the thoracic spine, erect posture may cause pain, or extension of your spine may cause significant pain. In the lumbar spine, because of the collapse will compress your nerve roots, they tend to present with shooting leg pain when they're standing up. So this is instability. So we have this scoring system called the spinal instability neoplastic scoring system. We don't strictly adhere to it, but when you have made a decision to operate on a patient, this acts as an addendum which will help you to sort of justify your decision. So it has composed of 6 categories. It has a scoring system of 18. Anything more than 13 is deemed to be unstable, and a surgery will be in the best interest of the patient. So the third alternative is this procedure called vertebroplasty or kyphoplasty. So this is strictly what we call is a vertebral augmentation procedure. It was initially introduced when older people have osteoporotic spinal fractures and significant pain. So what we do is basically, this is a very simple procedure. It takes a very short time, can be done even under sedation. So we introduce a couple of trocars under X-ray guidance into the patient's vertebral body through the pedicle. So through a couple of small stab incisions, and you introduce bone cement. We call it bone cement. The chemical name for it is polymethyl acrylate. So you can inject about 5 to 10 cc of bone cement into this. So this will, after about 5 to 6 minutes, it will cure, and it will cause exothermic reaction and solidify. While doing that, it will sort of gel the whole fractured vertebra, and is quite effective in relieving patients' pain. So this is indicated in patients who have intractable back pain with lytic lesions despite receiving radiotherapy. So there are certain prerequisites for vertebroplasty. Firstly, there should not be any spinal instability, any neurological deficit. And it should be a reasonably fresh fracture. So this is why we get an MRI scan. On the fat suppression weave, if we have a high signal, that means the fracture is quite recent. And I also would like to have a CT spine because that gives us the bony architecture quite well, because we prefer to have the posterior spinal body wall, vertebral body wall intact. If not, whatever the cement we inject into the body will seep into this neural foramen, into the epidural space. And its exothermic reaction may damage the spinal cord. So this is one of the most important sides, which I left to the end. So the most important thing, we know the indications for surgery. So there are certain factors you might have to consider when you're deciding whether you need to operate a patient or not. So the 2 most important questions is to answer is first, whether this patient could tolerate this surgery. Secondly, whether this patient will benefit from this surgery. So despite having the correct indication, we got to assess whether this patient has any significant systemic comorbidities, or whether this patient is anesthetically fit, because these surgeries may last for about 4 to 4.5 hours in a prone position, which is very physiologically demanding for the patient. Secondly, will this patient benefit from this surgery? It depends on the patient's tumor biology, how aggressive it is, his prognosis, and whether he has substantial recovery period to receive systemic treatment after the surgery, and especially whether there is any advanced systemic treatment available for this cancer. So just the last slide, I just wanted to briefly touch upon this thing called prognostic scoring system. So there are so many prognostic scoring systems in the literature which try to identify indications for surgery. Unfortunately, most of them tend to either overestimate or underestimate the life expectancy of a patient. I think one of the main criticisms is most of these have been designed by either spinal surgeons or radiologists, not by oncologists. So the main criticism is they are not giving any consideration to novel the systemic anti-cancer treatment. So rather than sticking into this rigid survival prediction, it's best to discuss with the oncologist a personalized chat about the patient and whether he will actually benefit from the surgery. That concludes my topic. Thank you very much.
Thank you very much, Dr. Hamid, for that very interesting presentation. That was very clear. Now it's the time for questions, and I'm pretty sure the audience will have some questions to our presenters.
Congratulations to all the speakers for those excellent talks. And few questions to Dr. Balavardhana. So you said DPD deficiency can be detected in Sri Lanka, and like what is the method and what's the cost and where is it available?
Big type, right? So most of the laboratories, I think, used to send that to Sri Lanka hospital. They somehow get it done. I don't know whether they are doing it locally or whether they are doing it by sending the specimen to India. But within 1 week, you can get the result, right? I think Gene Tech is also doing. But it is now, we don't see a lot of cases, but I have had some cases with fatal consequences after using 5FU. One of our very dear colleagues' father died after giving 5FU for esophageal malignancy. Okay, so there are two ways. One is the genotypic one, other one is the phenotypic. So genotypically, if it is heterozygous, you use only 50% of the 5FU. If there's homozygous, if the deficiency is homozygous, then you can't use 5FU at all.
Okay,
Right.
Thank you, sir. And also you said in patients with MSI, 5FU cannot be used. So what is the alternate drug?
No,
that you-
alternative, I mean, it's now usually now, say, if it is stage 2 colon cancer, where there are no nodes, but as an oncologist, you believe that chemotherapy might help. There are other bad prognosticators like, poor differentiation, right? And lymphovascular invasion, or other important thing is, inadequate sampling of the nodal number of nodes, less than 10 or 12. So I think we can use something like irinotecan-based chemotherapy. And there's another one called, I think, I'm not very sure, Relitrex. Just check it, Krishant, I'm not very sure. There is an alternative drug for 5FU. I think Relitrex, if I may remember that. I'm not very sure, but there are alternatives.
Okay, thank you, sir.
Yeah, that is correct, right? Relitrex. There you are. So I'm correct.
Thank you, sir. And Dr. Devinder, you said in renal impairment, the allopurinol dose needs to be adjusted. And how do you make that adjustment based on renal function?
Yeah, so generally up to mild to moderate renal impairment, you can use the full dose. The current recommendation is in the setting of tumor lysis syndrome. Actually, the proper dose, 300 milligrams per day, can be used until the creatinine clearance is 20 ml per minute. If it is 10 to 20, the dose must be reduced to 200 milligrams. And 5 to 10, also you can use 100 milligrams, but less than 5 you can't use.
Okay, thank you. And in high-risk febrile neutropenia, you said piptazo with amikacin. So have we got to combine amikacin right at the onset, or can we add amikacin for observing the patient for 48 hours?
Generally, in febrile neutropenia, we use the combination of piperacillin, tazobactam, and amikacin in our institution. So safe approach is to use the combination initially until the patient is stable. But later on, once the patient is clinically stable, if you want, you can exclude the amikacin. But if the patient is having renal impairment, it is contraindicated.
Thanks, Dr. Devinder. Sorry, anybody else wants to ask questions? Otherwise, I have one more question for Hamid. Why do you request a sagittal fat suppressed MRI? What's the significance of that?
Fat sup is one of the main important things because one thing is it will give us the if there is a lesion to identify whether this is inflammatory. So your radiologist sometimes will be able to tell you whether it is infective or it's cancerous. Sometimes we go into dilemma with especially our country when you have spinal TB also. Especially this is a problem when the patient does not have a prior cancer history. So when they come freshly with just the first manifestation being the spinal metastasis, then it's quite important to distinguish what exactly this lesion is. So fat suppression view becomes quite important. So in the same scenario, you might have to even request for a contrast scan also. If a patient has prior history of cancer and you have a lesion, it's most likely to be cancerous. So contrast might not be required at that moment, but a fat suppression view is quite essential in that sense. Secondly, like I mentioned, you need to, so if you're looking for some other alternative like vertebroplasty, it will also tell us if there's a high signal in stir images that is a very recent fracture. Because as I said, in vertebroplasty, you should have a potential space within the vertebral body to inject something. So with time, they tend to heal and there is no potential space in the body. So if you have high signal in stir, that means the fracture is quite recent and there is a void within the vertebral body where you can inject bone cement.
Thanks. Thank you so much.
Let me ask a question from one question from Dr. Hamid while we are waiting for the questions from the audience. So Dr. Hamid, now as hematologists, we come across a lot of multiple myeloma patients who have a lot of spinal metastasis. So sometimes they have the spinal cord compression, but we are sometimes very doubtful whether the orthopedic surgeons would be able to help us because there are a lot of metastasis and a lot of destruction in the adjoining vertebral bodies as well. So what would be your approach in that case as an orthopedic surgeon?
Yeah. So firstly, when it comes to myeloma, I think the problem is it's quite sensitive. So we try to, even the presence of sometimes neurology, if they have early intervention radiotherapy, we know that neurology may improve. But if they have spinal instability, despite that, so I told you it's an independent factor, which way we need to operate. But the dilemma is what you're trying to do. I had this encounter when I was as a fellow in UK, because there was this young lady who had myeloma. And then, so if they're young, could you even consider about the bone transplant approaches? So yes. This lady, so at the MDT, we concluded that, okay, this is myeloma. She did not have neurology, but significant cord compression at that point. So we said straight away, okay, for radiotherapy. But then again, after about 5 days, they called us and told us the patient's neurology is deteriorating. So then when retrospectively, when we checked, she actually had not received radiotherapy because they considered if it'll be unfit it'll not be in her best interest for bone marrow transplant if she receives radiotherapy. So that was a very important, so that was a lapse in communication. If they had actually told us, okay, this is what we intend to do for this patient, then for the emergency neural decompression, the best option would have been surgery. So that subsequently they could have considered about bone marrow transplant. So that is the first thing. Secondly, when we have to operate also, the challenges with myeloma is they tend to be widespread. So if you have instability, when we might have to resort to some advanced technique, for example, we had recently a patient who had multiple mets in all vertebrae and she was collapsing quite badly. So she was having spinal instability. So the other option is we have special instruments like the screws where you can insert the screw and inject the so-called bone cement through the screws. They are called cement augmented screws. Our problem is the pull-out strength. You can give them a surgery once and for all. So because once you radiated that skin, you can't go in, you know how complicated things may be. So we're trying to provide them one surgery and once and for all with maximum stability. So we tend to put the cement augmented screws so that the pull-out strength is better in them. But if they have neurology, I mean, the bottom line is our role here is to be quite supportive to you guys. We want to help you with whatever you want. So your input is quite important for us, what you expect from us. And the most important thing is when it comes to neurology, what I want to emphasize is lost neurology is quite time dependent. So this is not a surgery which should be done in the next possible elective list. So I try my level best to convince a lot of people because the immediate loss of neurology may be reversible, but with time, vascular injury may cause permanent disability. So we have lost the bus in that sense.
Yeah.
I hope it answers.
Yeah, that helps. Yeah. Having said that, radiotherapy is not a contraindication prior to autologous transplantation in multiple myeloma, but as long as now it's clearly indicated, we can go ahead and give it. I think Dr. Devinda would agree with me. And Dr. Devinda, the other thing, you can answer that question as well. And I haven't seen much data on whether to give radiotherapy prior to surgery, fixing by an orthopedic surgeon in multiple myeloma or afterwards. So what would be your recommendation or approach?
Yeah, so just to answer that the fact about this transplant and
Yeah.
radiotherapy. Yeah, as Dr. Buddha said, it's not a total contraindication for radiotherapy. The worry is that if the amount of bone marrow which is irradiated is large, then the stem cell collection can be affected. Generally, we try to avoid the lumbar and pelvic area, but small area can be irradiated. But always, it's better if we can avoid radiation. Yeah, again, the evidence-wise, we don't have much data about whether the radiation is safe to give prior or after surgery. But generally, we always tend to get the opinion of a neurosurgeon or orthopedic team about the surgical intervention prior to radiotherapy.
Yeah. And regarding neutropenia, now, during this COVID season, the pandemic, have you come across any situations where you see more neutropenia in COVID patients or post-COVID situations compared to what you see during the previous days?
Yeah, fortunately, I haven't noticed a huge difference. The one thing is that we are basically following up our hemato-oncological patients closely despite this COVID situation. In certain instances, things like lymphoma or myeloma, the initial presentation, I have noticed a delay in presentation. But the neutropenia wise, I haven't noticed a huge difference in the incidence in this post-COVID era, especially at least for this hematological malignancy. One reason maybe that we are closely following these leukemic patients despite our COVID, post-COVID era.
We can go for one short question again from Dr. Devinder. In renal failure with TLS, what do you mean by adequate hydration? So one of our Matthew Hamilton is asking this question on the chat. So.
Yeah, that's a great question. The adequate hydration in tumor lysis syndrome. Now, the general recommendation is to give hydration at a rate of 125 milliliters per square meter body surface area per hour. Generally, the pediatric patients, they usually tolerate hyperhydration. But when it comes to the adults, you have to be a little careful. The elderly patient above 65, 70 anyway do not tolerate hyperhydration. And adult patients sometimes have cardiac comorbidities, so they do not tolerate hyperhydration. And leukemic patients, initially at the time of presentation, their hemoglobin is generally low. So if the hemoglobin is less than 8, they do not tolerate hyperhydration. So such patients, if you start at a rate of 125 ml per hour, they will easily go into congestive cardiac failure and pulmonary edema within a matter of hours. So that can be even fatal. So in adults, when you are determining the rate of hydration, you have to be careful. You should take all those factors into consideration. For a young adult without any cardiac comorbidities with good hemoglobin might tolerate a rate of about 100 to 125 ml per hour. Elderly one, about 60, 65 years, with some cardiac comorbidities, they might tolerate only about 80 ml per hour. And if they have low hemoglobin, especially less than 8, they might even not tolerate 80 or 90 ml per hour. So in such patients, it may be only about 50, 60 ml per hour. So individually, you have to decide case by case. This is very important because I have seen that certain instances after starting hyperhydration for elderly patients, they will easily go into congestive cardiac failure.
Right. Thank you very much, Dr. Devinder. And thank you very much for the panelists. It's been a great session. It was very helpful. I think we don't have much time for questions. It's been 11:15 and we have to move on to the next part of the workshop, and we'll be back to questions at the end of that session. Thank you very much. Now let's move on to the next part of the workshop. Let me invite Dr. Sujiva Veerasinghe, consultant clinical oncologist at the National Cancer Institute, Maharagama, and Dr. Naduni Bulgoda, consultant clinical oncologist at the base hospital, Vavuniya, to the head table to start the next part of the workshop. And your tea will be served to your table. And while enjoying the tea, we can enjoy the next session. Can Dr. Sujiva Veerasinghe and Dr. Nadani Bulgoda take the seats up on this table, head table? Right, so the next lecture is on cancer pain management. So it'll be delivered by Dr. Sujiva Veerasinghe. Dr. Sujiva Veerasinghe is a long-standing member of the SLCO and has held positions as Vice President, Secretary, and a council member for many years. And she is a member of the Board of Study in Clinical Oncology at the PGIM, University of Colombo, and she's the chair of the Palliative Care Committee. And Dr. Veerasinghe has been a mentor, a teacher for many of us, and I've been extremely privileged and lucky to be molded by her as a registrar in my initial registrar days. She has a special interest in palliative care quality improvement. So over to you, madam.
Very good morning to everyone. Thank you, SLCO, for inviting me to do this presentation. We will look at how we manage pain in our cancer patients in our wards in day-to-day practice. As any term in oncology, pain also has a definition. It is an unpleasant emotional and sensory experience associated with actual or potential tissue damage. However, pain is highly objective. And to show the importance of pain, American Pain Society in 2003 named pain as the 5th vital sign. So it emphasizes importance of managing pain in cancer patients. If you look at pain, if someone is having pain, they get anxious, family worries, depression, sleep disturbances, impaired ambulation, medication worries, whether to take it, the side effects, and too many drugs. And also there is hospitalization, and also there is a cost involved when the patient is hospitalized. And all these causes the patient more anxiety and the pain get worse. How to break this cycle? To break this cycle, we need to do adequate pain control. Cancer pain is about 70 to 90% prevalent in cancer patients. At last month of life, it is about 60%. How we relieve pain. Goals of pain therapy. If we look at the goals, there are 5 A's. Number 1 is to optimize analgesia is one of our goals in managing cancer pain. And optimize active daily living is also important, and also to minimize the adverse effects. Aberrant drug taking has to be avoided. Actually, this is not a big problem in Sri Lanka. However, in other countries, this is a big problem. Like relationship between the brain and mood has to be improved with our management. How do we approach to achieve these goals? First and foremost is we need to routinely screen for pain. Patients might come and tell us, doctor, I'm having pain, but some patients don't do. We have to ask for their pain. If they say, even after asking, if there's no pain, are we still happy? No, we still have to anticipate the pain if they are getting pain, like in procedures and in future biopsies and all that. And also we need to rescreen time to time. After routine screening, if they had pain, we need to assess pain. And also, if the pain is very severe, if they are coming with severe pain, it is an emergency. Have you ever thought of this? The pain, acute pain is an emergency. Just as any other emergency in oncology like SVC obstruction and spinal cord injury, so pain is also an emergency. We will look at patient assessment and the acute management of severe pain a little bit in this presentation. We need to screen, rescreen during the process. It is very important. If you look at assessment, there are several mnemonics to remember how you assess the patient. This easy one, I like it, PQRST. P is for provocative factors, Q for quality, R for region and radiation, S for severity, T for timing. History and comprehensive clinical examination is very essential to assess this pain. And what is the aim of doing this comprehensive assessment? We first need to find out the patient's pain experience, how much the pain they have, and we have to find out the etiology of the pain and also the patient-specific goals. Sometimes some patients want zero pain. Some patients say, doctor, I don't mind having a little bit of pain, but let me allow me to walk, allow me to get down from the bed. So like that, their goals are different. And also we need to assess the risk of aberrant drug use. That is, if they might do morphine misuse, things like that. And in this assessment, you would have, all of you would have seen this numeric pain intensity scale. You need to explain to the patient very carefully about it. 1 to 3 is mild pain, 4 to 6 is moderate pain, and 7 to 10 is severe pain. So this is pain phase scale, and there are so many other scales for different types of patients. Next question is, what type of pain? There are 2 types, nociceptive and neuropathic. Nociceptive pain is somatic, from soft tissue, bone, and muscles. And visceral pain also under nociceptive, coming from visceral like bowel. Neuropathic pain could be compression of nerves or with destruction of nerves. So we will look at how do we manage. And when we talk about managing pain, no one can forget this WHO 3-step ladder. But here, for our cancer patients, there's important finding. Several studies have shown that this middle step is not very important in cancer pain management. We can go straight from step 1 to step 3. Tramadol and Vicodins are not very helpful in managing cancer. What are the drugs we do? You all know all these drugs. Which drug can I use? Next question is, which drug is for which pain? If you check visceral pain is totally responsive to opioids. You don't need to use any other adjuvant drugs for visceral pains like bowel pain. You just can give opioids. Soft tissue and bone pains are partially responsive to opioids. So you need to add NSAIDs. If it is bone, you need to add bisphosphonates also. Muscle spasm is not at all responsive to opioids. You always need to add muscle relaxant. Give only muscle relaxant for muscle spasm pain. Now, neuropathic pain is just partially responsive to opioids. In the compression, you need to add steroids plus anticonvulsant. In nerve destruction, if you detect, you need to add tricyclic antidepressants, anticonvulsants, and local anesthetics along with the opioids. However, you have to bear in mind that these pains are not occurring as very simply as visceral, soft tissue and bone, but all these could be mixed up, and there could be complex pain in in individual patients. When you have to be mindful on that when you are selecting the drugs. We will look at the basics of practical use of morphine. Question comes when you need to know what is the preferred route of chronic pain. Always the preferred route is oral. There are the many routes available, but for the chronic pain, preferred route is oral. What's the appropriate dose? Lowest dose that relieves patient's pain is the most appropriate dose. And it has to minimize functions during the period, maximize the functions during the period, and also there has to be manageable side effects. If you can have a dose to balance all these three factors, that is the patient's appropriate dose, very easy. And then comes the question, what is the maximum dose I can use? There's no ceiling. So you can go up to 100, 200, 300, 400, any amount if you are within the limits of the previous discussed facts. Actual milligrams does not matter, but this total number of milligrams is restricted just by side effects. This is a practical approach, how to start oral morphine. Always starting a patient with morphine, you have to use immediate release morphine. If patient is opioid naive, we can, if there's the patient having moderate pain, 2.5 milligrams per hourly is the dose. Severe pain, 5 milligrams per hourly. If the pain score is more than 5 or higher in a patient who is on maximum dose of weak opioids, some patients are on tramadol. If they are on tramadol about 300 to 400 per day, and they are still having more than 5 pain, you can straight away start morphine at 10 milligrams per hour. Remember to stop tramadol because both side effects overlap and it will do more harm than benefit by giving tramadol and morphine together. And then comes the rescue doses. However much you give round the clock pain relief, the patient may have time to time pain due to various reasons. Always for the rescued breakthrough pain, you use IR preparation. You know the reason for that. And the total, the dose of the morphine is either 1/6 total daily dose, or some people take 1/5 of the dose. More than one breakthrough dose in 24 hours indicate that you need to increase the regular dose. If they take 2 doses per day, you need to increase the regular dose. How do you increase? You add up the total breakthrough doses in the past 20 hours and increase the next day's total regular dose by this amount. Very easy, very easy. Conversion factor is like 3:1. Oral 30 milligram equivalent to IV or subcutaneous 10 milligrams. And treating a pain emergency. This is also very important. If a patient presents to you with very severe pain, how do you manage? Always use IV route, but some people prefer subcutaneous route. Teach the patient, you need to teach the patient the numeric pain score. And always sit by the patient's bedside. You can't leave the patient while doing IV titration of morphine. You don't have to be scared to do this. So if you follow these steps, you sit by bedside, titrate 1 milligram at a time till the pain score down to 2 out of 10. Like you can give every 5 minutes 1 milligram at a time. Then you give 1 milligram, then ask 5 minutes, you ask how is your pain? Still there is pain, you give another 1 milligram. Like that you continue to, this is called pain titration. And those needed for titration can be taken as the 4-hourly oral morphine dose. That means if 5 milligram of IV morphine used to control the pain to 2 out of 10, then your daily dose, the daily oral morphine regular dose is 15 milligrams multiplied by 3. given 4 hourly. Later on, after 24 to 48 hours, once the pain stabilizes, you can convert it to SR morphine or MST. And you would have seen transdermal fentanyl used in the wards. Use only in patients who are tolerant to opioid therapy, but you should not misuse transdermal fentanyl. It is very costly, and always the patient has to be very big dose of morphine, and there has to be a good reason to convert the patient to transdermal fentanyl. Never ever use in an opioid naive patient. It is never suitable for opioid pain titration, and it has a very slow onset of action, and this time to steady state also 17 to 48 hours. So that it shows that you need to give IR morphine up to 6 to 8 hours of the first patch. Even though you apply the first patch, patient still will not have enough pain control. So you need to control that initial part of the initial period with IR morphine. And also, it has a long washout period, 30 to 25 hours. So this is very important in the overdose management. Overdose management. Yeah. It is not suitable for acute post-operative pain. Remember, elimination half-life prolonged in elderly. And also, absorption increased by 1/3 with the rise of body temperature. If the patient having fever, the absorption may be fast, and you need to ask the patient not to go out if out can expose the febrile patch to the sun. Then there will be more absorption. Then you consider opioid side effects is also important. We especially concentrate on constipation, vomiting, and nausea. When we start initially morphine on a patient, always you need to start anti-constipation drugs. It is a must. And also, if you're starting initially, then they usually get nausea and vomiting in first 1 to 2 weeks. So you need to add antiemetic like domperidone for the first 1 to 2 weeks. Is it only opioids for cancer pain? No, there is so many other things like radiotherapy, chemotherapy for the debulking of tumor, interventional methods like nerve blocks, non-medical things like various heat therapy, physio, exercises, music and relaxation techniques, all those. However much we talk about pain control and however much we say that pain is a vital sign, there are a lot of barriers to pain control, which I have observed in our wards as well. And these are these are not just my thoughts, these are internationally accepted causes for the barriers for the pain control. One is attitudes of staff and knowledge deficit. That is the thing, the attitude of staff and the knowledge deficit. By doing these lectures, we are trying to minimize this. And also the patient part, patient may not report pain as they believe nothing can be done. They think this pain is their pain is part and parcel of their cancer. So poor patients believe like that. So they don't come out with importance of pain management. And also fear of becoming addicted to opioid. This present in both patients and the staff. You have to avoid that feeling. Forget that feeling as well. It is proven not so. I remember that pain, we describe pain as a cycle. So with that, there comes a total pain concept. That is like pain is not only physical. For someone's pain, the psychological, social, and spiritual factors also play a part. That is why in the wards, when you give patients analgesics, however much you give the patient's pain is not under control. So they are still having pain with the maximum doses of analgesics. That is why you need to do a proper assessment, like about the psychological, social, spiritual factors affecting on pain. It is so important, please remember. Cancer pain, about cancer pain management, please remember specific palliative debulking therapies, radiotherapy, radionuclide therapy, bisphosphonates, they are very important to consider. Cancer pain could be multifactorial, more than one type or site of pain can coexist. Mindful of that. Consider drug interactions and side effects. They are on various anti-cancer drugs and many other drugs. Consider the total pain. We just a few seconds ago we discussed the total pain management. Consider the pain as a total symptom, and we also need to overcome the barriers of pain control from our side and the patient side. Adequate pain relief is our aim. You are living pain. Enjoy the journey. Thank you.
Thank you very much, madam, for that very informative presentation. Let us now move on to the next presentation by Dr. Naduni Bulgoda. Again, a pre-recorded presentation will be played. Dr. Naduni Bulgoda is a clinical oncologist working currently at the base hospital Vaunia, and she plays a major role as a leader in the Young Oncologists Forum of the SLCO, and she makes a special contribution and effort to strengthen the knowledge and skills and expertise of young oncologists by networking and with other oncologists regionally as well as internationally. So let's listen to Dr. Bulgoda.
How we could avoid harming patients during our prescription. So just to recap, what is cancer? So cancer is due to imperfect DNA replication, which causes rapid mitosis of cells, and which in turn causes driver mutations, which drives the cancer to transform it and progression, and it leads on to metastasis. So basically, cancer cells they are very rapidly proliferating tumors, most of them, and this is used, and this fact is used when you're treating patients with traditional chemotherapy agents. So this is just to highlight the action of traditional chemotherapy agents. So as you can see, so cisplatin and carboplatin are alkylating agents, so they act by damaging DNA, and also antimetabolites such as gemcitabine and 5-FU also act by incorporating into DNA and preventing cell proliferation. And also, for example, taxanes and Winker alkaloids acts on the microtubule system, and then again, it also keeps on prevents rapid cell proliferation. So the downside of traditional chemotherapy is it does act on cancer cells. It does destroy cancer cells, which also destroys other normal cells as well, which are rapidly proliferating. So for example, hair follicles, GI epithelium cells, and bone marrow precursors, which are rapidly proliferating cells, are also damaged by traditional chemotherapy, leading to hair loss, mucositis, diarrhea, and also neutropenia and low platelets. So when we are treating patients with chemotherapy, we need to always look at the big picture. So for solid tumors, with the exception of germ cell tumors, chemotherapy has only a supporting role in cure. And radical intent treatment in cancer is only with surgery or radiotherapy to remove the tumor. So what's important is, so it's very important to identify this concept for safe prescribing, because we need to identify the intent of chemotherapy to prescribe chemotherapy, and also as well as to continue chemotherapy cycles. So for example, we treat patients in two intents, radical and palliative. So radical intent, the goal is to cure the cancer. So a primary treatment is done with surgery or radiotherapy, and chemotherapy is given as neoadjuvant or adjuvant to increase the survival. Whereas in a palliative treatment, the goal of treatment is to improve quality of life. So to move on, a little bit more about radical intent treatment. So for example, we'll take an example of a 38-year-old lady with a T3N2 triple negative breast cancer receiving neoadjuvant chemotherapy. So traditionally, we know this sort of a lady has a very chemosensitive tumor. However, we need to remember that for this lady, the 5-year survival with surgery alone is 45%. That means if she did not have chemotherapy, still there's a chance that she will be alive at 5 years of 45%. And we give chemotherapy to improve this 5-year survival to 60% and the 10-year survival to 48%. So chemotherapy is important to increase the survival, but also we should remember that surgery itself has a big role to play, and we need to make sure that that for radical intent patients, there is no mortality due to chemotherapy in the adjuvant setting, which is unacceptable because this lady would live for 5 years at 45%, even without chemotherapy. So we need to make sure that this chemotherapy is going to make her live longer than she actually would. So we need to be extra vigilant to avoid toxicity in the adjuvant setting while ensuring that the full dosage is delivered. And in contrast to this, in the palliative setting, the overall survival and disease-free survival is increased only by months from chemotherapy. For example, in most upper GI cancers, pancreas, cholangiocarcinomas, and stomach and squamous cell carcinoma of the lung. So the aim of treatment in the palliative setting is improving quality of life and to increase disease-free survival so that they will live a good quality life for the few months they are going to live. And so the patient assessment in the palliative setting in the chemotherapy clinic is different than in the radical setting. So we need to carefully assess symptoms in the palliative setting. We need to consider stopping treatment when toxicity impairs quality of life, because the precious few months of life we cannot destroy by giving toxic chemotherapy. And also the other issue is in the palliative setting, cancers develop resistance to chemotherapy quite often. So we need regular imaging is essential to identify resistance to prevent unnecessary treatment. So every 3 cycles of palliative chemotherapy, we need to assess, is this patient responding? Is the cancer responding? If not, we should stop it and stop unnecessary treatment. So with those basics in mind, let's move on to a few cases. So this case 1 is a 52-year-old lady with a locally advanced breast cancer, and she has no comorbidity, and she is on neoadjuvant chemotherapy, and she is seen in clinic on day 10 following her 3rd cycle of docetaxel. So in clinic, she's afebrile, but mentions she does have loose stools 3 times a day, and she does feel a bit tired. And her WBC count showed a WBC of 2.1 and an absolute neutrophil count of 1.3, which is more than 1,000, and 1,000 ANC, hemoglobin 11.5, and platelet 83,000. So she's afebrile and she's not neutropenic, and she's in the clinic. How would you manage her? So we need to move on with examination. So on examination, she had mucositis and she was dehydrated, and her vitals were compatible with stage 1 hypovolemic shock. So she was managed with a fluid resuscitation and IV antibiotics. And the next day, when her counts were checked, she became neutropenic. So the lesson here is we need to have a very high degree of suspicion to prevent mortality from neutropenic sepsis. And patients are not always febrile and they're not always neutropenic at presentation, especially when they come for routine counts. So we need to have a very high degree of suspicion to prevent this. Moving on to the second case. This is a 41-year-old male we see in a clinic, and this patient is on adjuvant treatment for colon cancer, awaiting cycle 5 of FOLFOX. He complains of difficulty in holding his cup of tea in the morning. He is able to go to work. How would you assess his suitability for the next cycle? Okay. So he's having onset of peripheral neuropathy, which can be identified by difficulty of buttoning clothes, holding objects, and writing. So we need to grade this peripheral neuropathy using the common toxicity criteria. So grade 1 peripheral neuropathy involves loss of deep tendon reflexes. Grade 2, objective sensory loss, but not affecting activities of daily living. Grade 3, objective sensory loss, but also affecting activities of daily living. And grade 4 is permanent sensory loss. So this patient has sensory loss, but he's able to go to work. So he's in grade 2 peripheral neuropathy. This is following oxaliplatin. So grade 1 or 2, less than 7 days, oxaliplatin dose, we continue the same dose. And grade 2 or 3, if it resolves before the next cycle, we need to do, if it does not resolve before the next cycle, we need to do a 25% dose reduction. So if this patient has persistent symptoms, he needs a dose reduction. If not, if it resolves, he can continue with the same dose. And in grade 3 toxicity, we need to stop the chemotherapy immediately. So just a word on oxaliplatin neurotoxicity. It is cumulative and dose dependent. So the more chemotherapy we give, the more higher the risk of oxaliplatin neuropathy during the latter cycles. It is fortunately reversible. It takes 13 weeks to reverse, and it's reversible only in 74% of patients. So 25% of patients is irreversible. And it takes 3 months, 13 weeks, it takes 3 months for the oxaliplatin neuropathy to reverse, and 3 months may seem a lot for a palliative patient to suffer from peripheral neuropathy and poor quality of life. So when we are prescribing in the palliative setting, we need to keep that in mind. Are we going to continue with oxaliplatin or not? But for this patient, this is a patient discussing the adjuvant setting on FOLFOX after stage 3 colon cancer. So for him, the 10-year overall survival is increased by 12% with the addition of oxaliplatin. Therefore, we need to carefully consider, is the increase in survival of 12% worth a permanent neuropathy when we decide on continuing oxaliplatin treatment? So other drugs that cause neuropathy, peripheral neuropathy, are platinums, taxanes, Lanka alkaloids, thalidomide, and bortezomib. So in clinic, when we see patients with on these drugs, we need to assess for peripheral neuropathy. Moving on to the third case. This is a 42-year-old lady with a carcinoma of ovary on first cycle of paclitaxel and carboplatin. So within 10 minutes of starting a paclitaxel infusion, she complains of chest tightness, giddiness, and felt that she's going to die. And she had an itchy rash and rigors. So the nurses quickly stopped the chemotherapy immediately and administered IV Piriton and IV hydrocortisone as per protocol. So questions of this lady: what grade is this reaction? What initial management, after initial management, her symptoms resolve, and how would you manage her next? And third question is, can this chemotherapy, paclitaxel carboplatin, given as an outpatient? So moving on to the first question. So anaphylaxis is graded as mild, moderate, and severe. So this lady had rigors and fever, and she had the feeling of impending doom, and she had mild bronchospasm and chest discomfort, which all falls into the category of moderate anaphylaxis. But she did not have features of severe anaphylaxis, which include dyspnea, vomiting, hypotension, tachycardia, and audible wheezing and bronchospasm. So in the history, she had temperature, impending doom, chest tightness, and a rash. On examination, no audible wheeze, and blood pressure was stable, so she had a moderate reaction. So it's very important not to stop a chemotherapy just because the patient has some test, not to categorize a patient with chest tightness as having a severe reaction. So management of moderate anaphylaxis is after performing what was done by the nurses. You need to keep on recording vital signs every 15 to 30 minutes until the patient stabilizes, and record that this is a drug reaction and record the severity of it, and give oxygen therapy if saturation falls below 95%. Keep on monitoring vital signs, and once the reaction subsides and vital signs are normal for 1 hour, we can re-challenge the patient with a slower infusion rate. of 20 milliliters over 15 minutes starting and then gradually increasing, and continue with close monitoring. And as for the third question, can paclitaxel carboplatin be given as outpatient? Well, yes. Most chemotherapy schedules can be safely given without overnight prior admission, as long as oral dexamethasone pre-medication is taken by the patient. So moving on to a different case scenario. This is regarding repeat chemotherapy cycles that we give in the clinic. So once the first prescription is written, we repeat the cycles, say four cycles of AAC, followed by 4 cycles of docetaxel, like that. So when we are repeating chemotherapy for the following common chemotherapy drugs, what would you assess before prescribing the next cycle? And when will you not prescribe or modify the next cycle? So for example, let's take capecitabine. So you have a patient in clinic on capecitabine. What would you assess clinically to decide on the next cycle? And what bilirubin level, ALT and creatinine would you accept to go ahead for the next cycle? And what about docetaxel? The same thing. What assessment clinically? What bilirubin level, ALT and creatinine would you accept? Oxaliplatin, etoposide, gemcitabine, vinorelbine, methotrexate, irinotecan. What would you assess clinically? What bilirubin, ALT, and creatinine would you accept to proceed with the next cycle of chemotherapy? Because we do it every day in the clinic. So it's good to sort of think about how we would face this scenario. So, just a word on chemotherapy in liver impairment. So drugs that are mainly metabolized in the liver cause excessive toxicity as they remain in the body for prolonged periods of time. So this would increase the risk of neutropenia and etc. other toxicities, because there is a higher concentration of the drug due to impaired liver metabolism. Examples of such drugs are vinca alkaloids, paclitaxel, docetaxel, irinotecan, doxorubicin, and epirubicin. So these are the dose modifications we need to do. So if we have a look, so for doxorubicin or epirubicin, if bilirubin is more than 1.1 milligram per deciliter, that is slightly just above normal, you need to do a 50% dose reduction. So this is really important, especially in the palliative setting where we give weekly epirubicin for patients with liver metastasis from breast cancer. So we need to make sure that the bilirubin is within the normal range, within this range, or we need to do appropriate dose reduction to prevent unnecessary toxicity such as neutropenic sepsis. And this also goes for etoposide, irinotecan, omit if bilirubin is more than 1.5 upper limit times of normal, that is bilirubin of 1.5, we need to omit irinotecan. And paclitaxel, we need to avoid if bilirubin is more than 1.25, just above normal. That's because if we do give paclitaxel, it should be a clinical decision, as there's a very high risk of neutropenia due to impaired paclitaxel excretion. And this is the same with docetaxel, bilirubin more than 1.2 or ALT more than 3.5 upper limits of normal, we should avoid docetaxel. And so is vinorelbine, which is commonly given for massive hepatic metastasis. It is relatively safe than the above drugs, but still we need to make sure the bilirubin and the dose reduction is appropriate. Moving on to renal impairment, there is increased toxicity of renally excreted drugs. And examples of drugs that are excreted renally are capecitabine, which is a very common drug given in the clinic, carboplatin, cisplatin, bleomycin, etoposide, gemcitabine, and methotrexate. So if you are giving capecitabine to a patient, we need to make sure that creatinine clearance is above 50 to give the full dose. If it's between 30 and 50, we need to do a 75% dose reduction. And also for cisplatin, we need to do an appropriate dose reduction. And carboplatin we can give because we are giving it according to the Cockcroft-Gawn formula, but we have to omit carboplatin if creatinine is more than creatinine clearance is less than 30. Less than 20. And methotrexate, etoposide, gemcitabine is a clinical decision, but we might need to avoid if the creatinine clearance is getting lower than 30 milliliters per minute. So moving on to other types of systemic anti-cancer treatment. So we discussed traditional chemotherapy with examples of how to prevent toxicity. So we also have targeted treatments, which are monoclonal antibodies, just trastuzumab, bevacizumab, and you've got small molecules, which are also targeted treatments, sorafenib, gefitinib, oximetinib, and you've got hormones, which are also targeted, abiraterone, anastrozole. And so these are treatments, targeted treatments are, they are specific, they act on specific genetic targets that are altered in cancer cells. But however, they have different toxicities from traditional chemotherapy. And we also have immunotherapy, which is enhancing of our immune system to kill cancer cells, such as nivolumab and pembrolizumab. And it also has a different toxicity profile. So comparison of systemic anti-cancer treatments. So if you go to traditional chemotherapy, it works by targets rapidly dividing cells, mostly cancer cells, and side effects, as we discussed, are hair loss and bone marrow suppression, etc. And its limitations are it's non-specific, and it always develops resistance mechanisms as tumor cells progress. Whereas targeted therapy targets proteins required for cancer growth, but it doesn't have the traditional side effects, but it does have its own side effects, which are unique to the target that it is targeting. So it's skin rashes, liver problems, anaphylaxis, and so on. And they're quite expensive, but eventually for these targets also, cancer cells develop resistance at some point. And immunotherapy, which use our immune system to fight against cancer cells. So we enhance our immune system to kill off cancer cells. And as a result, the side effect is having an increased autoimmune reaction. So we have an increased immune response. So we have more autoimmune side effects. And its limitations are it can only be used mostly if there are specific targets expressed, and in most instances. And also immunotherapy is extremely expensive, and for one patient, it costs millions of rupees for a treatment for one patient. So just an example of a side effect of targeted therapy. So if you take bevacizumab, it inhibits the vascular endothelial growth factor. So it inhibits it in cancer cells as well as normal cells. So it affects wound healing, and it reduces renal perfusion and affects blood pressure. So we need to monitor blood pressure and check protein in urine in each clinic visit and adjust dose when we are treating with bevacizumab. So this is just an example of how targeted treatments have its own side toxicity profile. So as we move on in chemotherapy in oncology, as more and more newer drugs are developed, safe prescription is paramount with newer agents as well as it is with traditional chemotherapeutic agents. So I like to conclude my talk from Epidemics Book 1 of the Hippocratic School. Practice two things in your dealings with disease: either help or do not harm the patient. Thank you.
Thank you very much, Naduni, for that very precise, concise presentation. Now it's time for our questions again. The audience joining us online can use the Zoom platform to send your questions across to us, and any of you in the audience can ask questions now from our panelists. Right, there's one question to Dr. Sujiva Veerasinghe. In patients with renal failure, what would be the best analgesic that we can use?
In renal failure, morphine can be used. Fentanyl also can be used, but we have to space the dose. The frequency has to be reduced, or if we are giving continuous infusion, the dose has to be calculated according to the GFR.
Right. Madam, there's another question. What is the place of transelectrical nerve stimulation method in patients with severe pain on initial presentation, can it be used as a first line or after using opioids? That's mainly.
I'm not sure whether it can be used as first line. Honestly, I'm not sure about it.
I think it should be asked from a neurologist. Yeah. And how will you adjust the doses of morphine in liver impairment? Another question.
In liver impairment, there's usually we don't really has to look at since it is not excreted by liver, but in patients with liver failure, still you can give spaced out doses and reduce depending on the patient development of patient's side effects.
All right. Any questions from the audience? Yeah.
Question to Dr. Sujiva. Me having a genetics background, this is a genetics question actually.
That's Dr. Chandramali Punchiheva, by the way.
Sorry, yes. Introduce myself. I have read about ultra-rapid metabolizers of tramadol and codeines that results in respiratory depression, life-threatening levels, and for that CYP2 D6 gene testing, I think is what relate that to. Is it done? I mean, is it practically done or is it required to be done?
Yeah, it is definitely required. But at the moment, in our country, the level, we usually do not do that in practice, but in advanced pain management, it is definitely required.
Related to the previous workshop, can I ask one question from you, Dr. Punchiheva? Like,
yes.
Is there any method that we can do G6PD deficiency detection in here in Sri Lanka? G6PD deficiency, like in respiratory case, we have to like. We don't have respiratory case at the moment, but we can get it down from India if needed.
Yeah.
We can't give it for patients with G6PD deficiency, particularly the pediatric patients. Dr. Sanjeeva, do you have any idea?
So the Indians use it before without checking G6PD deficiency. I think it's going to be available to us fairly soon. So our plan is, even if we can't do it immediately, to use it.
Right.
Can I follow up on that? Just a comment on the cutoff values for the liver enzymes and the bilirubin in Dr. Ibulgoda's presentation. I think they have to be taken more as a guideline rather than strict cutoffs. So for things like high dose methotrexate in osteosarcomas, where we give MTX in 2 consecutive weeks, the protocol itself says that you can go up to 10 times the upper normal limit of the transaminases. But we, in practice, we go even beyond that. The patient is clinically well and bilirubin is normal. And even in ALL, things like ALL, because of the liver infiltrations, when the bilirubin is high, in induction chemotherapy, even when bilirubin is high, we have a usually higher threshold for coming down on the chemotherapy agents. So those, I think, when you consider these cutoffs, it should be more of a guideline rather than exact figures.
Thank you for that comment. And we can talk in length about individual drugs. And what I have observed in our clinics in day-to-day practice is that some of the dose adjustments do not happen. Now, for example, for bortezomib, I've seen patients with presenting with very late stages of peripheral neuropathy, but the dose adjustments have not happened. Now, we have to adjust as we go along, as like I'm talking to the medical officers particularly. So when it's you who come across these patients on regular follow-up, sometimes they are not seen by the consultants. So when you assess the patients, particularly multiple myeloma patients, you have to regularly assess them for peripheral neuropathy, particularly with bortezomib. For diarrheas, diarrheas can be caused by bortezomib. So you have to make those adjustments. So you have to have a rough idea of how you adjust the doses. Now, for example, bortezomib, if you have grade 1 neuropathy, so you have to have a rough idea of grading. So if you have grade 1 neuropathy, there's no dose adjustments. So grade 2 or grade 1 with pain, you reduce the dose from 1.3 milligrams per square meter to 1 milligram per square meter. And if it's grade 2 with grade 2 or grade 3 or grade 2 with pain, then you reduce the dose to 0.7 milligrams per square meter. So likewise, and if there's severe autonomic neuropathy or severe pain, then you have to stop the drug. So without waiting the patient to have very severe grades of neuropathy, you have to adjust the doses. So we can give many examples like that. Vincristine is the same. And another thing, like I have seen vincristine being delayed and vincristine being stopped with neutropenia. Sometimes, for example, in patients who are on vincristine alone or some ALL patients, so you sometimes avoid giving vincristine, but just a simple thing that vincristine doesn't cause much neutropenia. The main side effect of vincristine is hepatic side effects. And another important thing for our medical officers and the junior doctors would be regarding rituximab. I think Dr. Devinda will also be able to give some comments on it. So I have seen a lot of issues in our ward setup. Can Dr. Devinda have a mic, please? So I have seen a lot of issues giving rituximab in our ward setup. So I have seen patients on rituximab who, with the slightest side effect, with a slightest chill or IGO, it's being stopped. But that's not the best way to give rituximab to the patients. Dr. Devinda?
Yeah, no. When you are starting rituximab at the beginning, the pre-medication is important. And the rate of infusion is also important. Usually you start at a very low rate, 50 ml per hour. And if the patient is developing any signs of reaction, you can temporarily withhold the infusion and then attend to the patient. But once the patient improves with the symptoms, you can restart, re-challenge with the rituximab, probably starting at an even slower rate. So mild to moderate reaction is not an it's not a contraindication for rituximab. You can re-challenge at a slower rate. It's only with severe reactions that you are a bit worried and might think of omitting the infusion.
Yeah, sometimes we can, like, if the patient develops a mild reaction, we can stop, and then after about a half an hour later, we can restart at a half the rate.
Exactly,
yeah. And sometimes if they even develop moderate side effects, we can, start a drip of like hydrocortisone along with rituximab. We can overcome the side effects of rituximab and try to give it.
Another way is that usually rituximab we give in combination with CHOP or CVP. So we have this prednisolone in this chemo regime. So if the patient develops any early reaction in the first infusion, you can start prednisolone a day or two earlier in the next chemo regime. So that be sometimes very helpful to reduce the incidence of reactions.
So that's a great point. And Dr. Naduni Bulgada has a feedback form. Sorry, I forgot to mention that earlier for you. So regarding her lecture, so please be kind enough to fill that as well. There's another question from back there.
Thank you very much. I'm an oncologist from Maldives. We actually recently started cancer treatment this year in our country. One question I have regarding pain management. When we're using morphine in very late stage cancer patients in the palliative setting, I've seen that many of our patients develop delirium. What can I do for the dose adjustments, or should I stop morphine if there is delirium? What can I do about it? Yeah, thank you.
Sorry, I didn't hear what is the side effect you
Yeah,
observed?
delirium.
Delirium.
Yes.
Okay. Yes. Actually, when you give morphine infusion, you mean morphine infusion?
Yes.
Yeah. If first of all, you have to find out the delirium, the cause for the delirium, whether it is just really due to the morphine or any other reason. And if the patient is on morphine infusion, we need to always adjust the dose according to the side effect. So if you think delirium is, yeah, you can adjust you can reduce the dose, or depending on the severity, you may have to stop and observe.
Is it possible to switch to another opioid?
If the patient develop delirium, we need to start haloperidol as well, and we can switch to another opioid as well. At the same time, you can restart as well, depending on the response.
Thank you very much.
Physiological tolerance and the addiction of the morphine, it will be helpful for the medical officers. Even the physiological tolerance, they think it is the addiction and stop the morphine, or they are not increase the dose. They told it is the addiction. I think it is, if you explain the clinically how to differentiate the physiological tolerance of the morphine and the addiction, it might be helpful for the medical officers there.
Yeah, in addiction, actually, usually what we have to say is in clinical use of morphine for the pain, usually it is the development of addiction is very, very low, almost zero. But there are, if it is very long term use, it has been shown. But physiological tolerance is the sometimes when the patient come and tell us that he need more and more morphine, we may have to find out with good assessment whether the patient actually asking morphine for his actual pain, or whether he's just asking for the misuse factor. We need to really assess and reassess the patient every time they come and tell us asking morphine, new prescription for an increased dose. Actually, if you suspect whether the patient is not really having pain, and his psychological status assessment is also important. That's why I was telling about the total pain concept in pain management. You need sometimes, if you think there is psychological factor influences the pain, and the pain, not only for the pain, about the drug therapy for the pain control, definitely a help of the psychiatrist is really needed in assessing properly, whether whether you really the patient really is addicted, or whether he is really having pain, in addition to your assessment for the pain.
Thank you very much, Madam. And Dr. Nadini Bulgoda, any comments?
So I'd like to thank Dr. Sanjeev for his comment regarding osteosarcoma and bilirubin. So it's really interesting to get a pediatric oncologist's point of view as well regarding this talk. So, why I mentioned those cutoff levels is mainly because my talk is based on solid cancers in adults. And these cutoffs are usually valid for most solid cancers in adults, and especially in the palliative setting, because in my talk, I mentioned that it's very important to differentiate radical from palliative treatment. And when we are giving palliative treatment, we should always do no harm. And that's why you should always check the tolerance levels, check the bilirubins, check the liver functions, check the renal functions, and see whether can this patient tolerate this. So I just want to re-emphasize on that the levels I've given is mainly for the palliative setting in adult solid cancers. Thank you.
Thank you very much, Naduni. I think we now have to conclude our first workshop. Let me thank our panelists of the second half of our workshop, Dr. Sujiva Veerasinghe and Dr. Naduni Bulgoda. Thank you very much for your kind contribution. And let me now invite Dr. A.J. Hilmi, the president of the Sri Lanka College of Oncologists, and the secretary of the Sri Lanka College of Oncologists, Dr. Sachini Rasnayaka, on the stage to deliver the tokens of appreciation to our speakers of our first workshop. So let me invite Dr. A.J. Hilmi to present the first token of appreciation to our one and only Dr. Jayantha Balawardena. And now Dr. Devendra Jayatilaka. And then to our orthopedic surgeon, Dr. M.S. Hamid. And Dr. Sujiva Veerasinghe. And Dr. Naduni Bulgoda as well. Thank you very much, ladies and gentlemen. Thank you very much. And it brings us to the end of the first workshop of our pre-Congress sessions, or the annual academic sessions 2021. Dr. Nurad Joseph, consultant clinical oncologist, is ready to have a very interactive workshop with you shortly. So there will be a very distinguished faculty of international speakers joining us virtually for this workshop. So please join us at 1:15 p.m. and have a pleasant day. Thank you very much. So your lunch, one of the most important items in the schedule, will be ready by 12:30. So don't worry, it'll be ready by 12:30. And you'll be back here by 1:15. Thank you.
Introducing science-based nutrition for the first time in Sri Lanka. Introducing NutriCan, special nutrition specifically formulated to help prevent severe weight loss, known as cachexia in chronic disease patients such as cancer. NutriCan is enriched with high energy for improved rehabilitation, high protein with BCAA to stimulate muscle repair and strengthen immune function, omega-3 to enhance the chemotherapy efficacy and improve cardiovascular function, high fiber for improved digestion and better nutrition absorption, DHA and EPA to reduce cellular inflammation and improve brain function post-chemotherapy, 11 vitamins and 10 minerals. NutriCan is strawberry flavored. Colby science-based medical nutrition formulations are developed adhering to the highest standard of manufacturing processes and quality assurances. We will continue to give the best to help your life.
Selenco Healthcare Services proudly presents a revolution in cancer treatment. Introducing the Tumour therapy treatment system.
Introducing science-based nutrition for the first time in Sri Lanka. Introducing Nutrican, special nutrition specifically formulated to help prevent severe weight loss, known as
This is an
cachexia in
announcement to
chronic
everyone.
disease
The lunch
patients
is
such as
open
cancer.
at the back of this hall,
Nutrican
which
is
the,
enriched with
Salon
high
No
energy
Kid.
for
Please,
improved
serve
rehabilitation,
yourself. The
high
lunch is
protein with BCAA to stimulate muscle repair and strengthen immune function, omega-3 to enhance the chemotherapy efficacy and improve cardiovascular function, high fiber for improved digestion and better nutrition absorption, DHA and EPA to reduce cellular inflammation and improve brain function post-chemotherapy, 11 vitamins and 10 minerals. Nutrican is strawberry flavored. Colby science-based medical nutrition formulations are developed adhering to the highest standard of manufacturing. We will continue to give the best to help your life. Introducing science-based nutrition for the first time in Sri Lanka. Introducing NutriCan, special nutrition specifically formulated to help prevent severe weight loss, known as cachexia in chronic disease patients such as cancer. NutriCan is enriched with high energy for improved rehabilitation, high protein,